Good morning, students. This is Dr. Vishal Associate Professor, ENT Department. Today's our lecture is on epistaxis. So we all know about the epistaxis. It means this is the bleeding from the nose. It is from the inside of the nose, and it is a very common situation. We all encounter this situation in our daily routine with many patients do present with even a small child to elderly population. They all present with this problem. Almost all the age groups can be presented with this kind of situation or the symptom. There are two types of epistaxis. One is anterior and the posterior. The anterior one is more common, and the most common site of the anterior bleeding is the anterior septum. Now, before understanding the etiology and pathophysiology of the epistaxis, we need to understand the blood supply of the nose. So we can say the nose is supplied with both internal as well as the external carotid artery. The branch of the internal carotid which supplies the nose is the ophthalmic artery, which gives an anterior and posterior ethmoidal arteries. And the external carotid artery gives a maxillary artery, which gives an branch of a sphenopalatine artery, and a greater palatine artery, which again gives a septal branch. External carotid gives another branch, which is the facial artery, and it supplies the nose via the superior labial artery and through its septal branch. There is a plexus of four arteries in the anterior part of the septum, which is known as the Kieselbach's plexus, and then this area is known as the Little's area. It is the region in the inferior part of the nasal septum where there is a confluence of the four different arteries which forming the plexus, and it is the most common site of the bleeding from the nose. The most common site of consists of the anterior ethmoidal artery, which is we commonly know as the anterior epistaxis. The sphenopalatine artery, which gives rise to the posterior epistaxis, and the internal maxillary branches, and which supplies the inferior turbinate, and they form a big venous plexus, and that is what the inferior turbinate they swell up during many conditions of the nose. So we'll discuss little bit in details about the Little's area, which is the Kieselbach's plexus, and it is the anterior inferior part of the septum. It is the most common site of the epistaxis in children. Four major arteries, except the posterior ethmoidal artery, takes part in the formation of Kieselbach's plexus, and the fingernail trauma, or the nose picking, is the common cause in children, especially. The drying effect of the inspiratory air current is again a common cause, especially in the countries like India, where the summer is going common, and the tropical countries. But one thing is good that this anterior epistaxis, which is from the Kiesel plexus, the bleeding is not that severe, and it usually stops by itself, and actually it is an arterial bleed, but it are the very small artery of the septal branches which give rise to this uh, bleedings. But it is very not very severe bleeding. It is the two types of epistaxis. One is the anterior and the posterior. Anterior one is more common and less severe, and it's easy to control. where the posterior epistaxis is less common, it's more severe, and it's difficult to control. If we classify the anterior epistaxis and posterior epistaxis, it is more common, anterior one, and it's from the little's area or the anterior part of the lateral wall. Most common in children and young adults. Most common cause is the trauma, and usually it is mild and can be easily controlled by the local pressure or the anterior packs. Whereas the posterior epistaxis is less common, mostly from the posterior superior part of the nasal cavity, usually in the later part of their life in the after 40 years of age, and usually this type of epistaxis is spontaneous and often due to the hypertension or the arteriosclerosis, and it prevents the spontaneous vasospasm, and so it is difficult to control. It usually requires the hospitalization of the patient, and the bleeding is severe. We need the anterior as well as the posterior nasal packs to control the state of epistaxis. In the pathophysiology and etiology, there must be the local causes like dryness leading to the crust formation. Bleeding occurs when the removal of the crust by the nose picking or rubbing or the blowing, especially when the patient is already having some deviated nasal septum, and this deviated part is more exposed for the drying current or drying effect of the air current, especially in the tropical countries. Second is the trauma, local cause in the trauma, which like a direct blow on the nose. Third is it can be an infective pathology, etiology that can be acute viral rhinitis and the nasal diphtheria. Acute sinusitis can be the very common causes, especially where these infections are common in the part of the country. Foreign bodies, non-living things, and the neglected foreign bodies remain there for a long period, and then ultimately they cause the inflammation and the granulation formation. They cause the nasal bleedings. The fifth is the atmospheric pressure change. The high altitude, sudden change in the pressure, like in the Kazan's disease, is also a common cause for the bleeding, and it is mostly from the anterior part of the nose. The deviated nasal septum, as I already told you, that this can be a common cause for the deviated epistaxis, especially because of the drying effect of the air current on the deviated part of the nose. Systemic, there must be some systemic causes also, like hypertension, arteriosclerosis, renal disease, bleeding disorders. Idiopathic causes are like when we are not able to find out any specific reasons behind the this thing. Liver disease, hepatic cirrhosis, they basically there will be some deficiency of the coagulation factors, and so patient will have bleeding tendencies, and especially from the nose when they're very delicate and small blood vessels and very superficially submucosal layer they are present. Disorders of the blood and the blood vessels like aplastic anemia, leukemia, thrombocytopenia, and vascular purpura, hemophilia, Christian disease, Christmas disease, and the scurvy, vitamin C deficiency, vitamin K deficiency. They are also very common systemic causes for the epistaxis. Now we come to the management part. Uh, the first and foremost important in this the management of the epistaxis, like any other disease, the history taking. We need to take the detailed history from the patient as well as from the attendants also to get the uh, good history of whether there was a history of trauma or any bleeding tendencies in the past, or exactly how this started, and what was the amount of the bleeding. Everything is important to reach on a diagnosis. Now we come to the first and foremost important thing in management is to control the bleeding first, and then because as the bleeding increases, there might be some hypovolemic shock if the bleeding is severe. So the first aid to stop the bleeding without knowing the cause is more important. So nasal packings or the direct cauterization of the bleeding site or the artery if we are able to see the bleeding point. So it is important. And after that, medical treatment for to rule out the any cardiovascular pathology behind it, and we need to stabilize the vitals of the patient. Like if the patient, we don't know how much already the patient has bled, so we need to see that the patient should be hemodynamically stable. Um, then finally, once the bleeding is stopped and then it is under control, we need to find out the underlying cause and treat it for a definitive management, and to be sure that it won't recur again. So the diagnostic evaluation, the first is the history is more important. I will take it in detail, that including the amount of blood loss, duration of the blood loss, whether the patient is already taking some medicines for some cardiac reason, they are blood thinners or antiplatelets, the side of the nose from where the bleeding was happening or occurring, and any known bleeding tendencies of the patient and in the family as well as. The second part is the careful inspection with the nasal speculum to determine the site of bleeding, and it's very important to determine which site of the bleeding bled first. And the third is the laboratory investigation simultaneously should be done to exclude any blood bleeding tendencies or the blood dyscrasias and the coagulopathies. Now we come to the medical management uh, of the epistaxis. The management of the epistaxis depends on the location of the bleeding site. A nasal speculum or the headlight may be used to determine the site of bleeding in the nasal cavity. Most nosebleeds originate from the anterior portion of the nose. The initial treatment might be include the applying the direct pressure. Little's area is the most common site of the bleeding from the nose, and the pinching of the nose with the thumb and the index finger for about 5 minutes in view of the compression of the vessels is important. The Trotter's method is again important. The patient is made to sit and lean forwards over a basin to spit any of the blood which is trickling down the throat, and it should not be like aspirated or swallowed, because in later the hours, the patient who has swallowed a lot of blood, patient will end up having a severe gastritis, because it's blood clots in the stomach. They cause very much irritation of the gastric mucosa. So patient should be able to breathe quietly from the mouth, and the cold compresses over the nose uh, uh, to cause the vasoconstriction, and as well as the pinching of the nose is important for the first aid. This is the Trotter method depicted. It the patient is it is sitting comfortably, bending forwards and pinching the nose, and at the same time you can apply some uh, ice over the nose, dorsum of the nose. When the origin of the bleeding cannot be identified, nose may be packed with a gauze impregnated with the petroleum jelly just to make it soft, and antibiotic ointment. A topical anesthetic spray just to reduce the pain during the procedure, and the decongestant agents may be used prior to inserting the gauze packing, or a balloon inflated catheter can also be used. Especially this the Foley's catheter, we use it for the posterior bleeding, just to pack the posterior nasal pack. This is the antenasal packing. You can see that from anteriorly we are packing the nose layer by layer, that the whole cavity is packed. The basic fundamental of this pack is to apply pressure on the both. The antenasal packing is done bilaterally because the pressure definitely will be more if we pack the nose bilaterally. The nasal packing with the bayonet tippet and the forceps and a ribbon gauge is important. They are the specific forceps for the nasal packing. We can't be just doing with any of the any common instruments. Nowadays, we are having the tampoons or the merosil sinus packs, which are very easy. There are ready-made packs are available. They are non-adherent, non-sticky. We just apply the ointment over the nasal packs and insert along the nasal floor directly towards the nasopharynx and put some saline or the hemostatic solution to, and as this nasal packs, they absorb a lot of liquid, they swell up and then on their own, and they apply pressure over the bleeding site. So it is very easy nowadays to pack it. The alternative, a cotton tampon may be used to try in stopping the bleeding from the nose if the meroseals are not available. So we need to have a proper and strong suction to remove the excess blood and clot from the inspection. And after removing seeing the nasal cavity from inside, then we can put the nasal packs in. So there are some cotton pledges are also available. They are very small in size, and we can just put with the help of a bayonet shaped forceps. And if the bleeding is from anterior aspect, then definitely the small padget from the both the sides of the nasal cavity will stop bleeding. The packing, once done, it should be left in place for at least 48 hours or up to the 5 to 6 days if necessary to control the bleeding. But 48 hours is more than enough, and antibiotics should also be prescribed whenever there is a risk of infection, because whenever there is a pack inside the nose, this will act as an foreign body, and then there will be chances of infection in the nose, and the infection can go into the blood, and the patient may end up having an atherosclerotic sinusitis. And the more talking about the more severe complications like an toxic shock syndrome. So patient should be on a prophylactic antibiotics once the nasal packs are inside the nose. So this is the kind of nasal packing. It's along with the anti-nasal packing. We keep a roller pack on the behind of the nose. We pull the one thread from the mouth and another from the anterior nasal cavity. So this is the method how we do the posterior nasal packing. So in definitive treatment, if we are able to see the site of the bleeding or the bleeding artery, we can just identify the site and cauterize it or seal it. There are two ways of uh, stopping the bleeding or the cauterization. One is the chemical cauterization, and that too we do with silver nitrate. And another is the electrocauterization, which we have the electrocautery in our operation theater room or in the emergency room. We can just cauterize the part and directly by touching on the bleeding point. Now we come to the surgical management of the epistaxis. If the underlying cause is the deviated nasal septum, so the SMR or the septoplasty is the treatment, and that will prevent any recurrence of the bleeding. Ligation of the vessel, even after packing, if We are not able to stop the bleeding, so we will identify the site of bleeding and accordingly we can ligate the respective supplying or main vessel, like and we can block the maxillary artery, we can block the ethmoidal arteries, and then we can sphenopalatine artery. And to in more severe cases, we can just directly ligate the external carotid artery also. And if there is another nasal mass or any other bleeding polypus, we can just directly go for after imaging, obviously, for the definitive surgery of removing the underlying cause. So, what may be the complications of epistaxis? Septic shock, which if the underlying cause is some infective pathology, then patient may go into the septic shock, and if the bleeding amount was very much severe, then definitely the patient can have a hemorrhagic shock because of the nasal packings and blockage of the opening of the sinuses. The patient can have a sinusitis, and if there is a trauma and there is a and, fracture of the cribriform plate or maybe the posterior table of the sphenoid sinuses. Patient can have a pneumocephalus, like the air entrapment in the brain parenchyma or in the subdural space only. Patient, because of the excessive pressure, there will be necrosis of the septal cartilage, and the patient ultimately will end up having a septal perforation. Another thing, the neurogenic syncope during packing, and because at the time patient is already having a lot of bleeding and then already had an hemorrhagic shock. So while packing with the this thing, if the patient, if the instrument hits somewhere and it irritates the uh, nasal mucosa, then now then the patient can go into the vasovagal attack. So always the nasal packing should be done under uh, and local sprays, anesthetic sprays, and in the lying down position only, not in a sitting position. Patient, because of the nasal blockage of because of these packs, patient is not able to breathe properly, is not able to properly breathe from the mouth, as we all know that as in human beings we are actually obligate nasal breathers, and so there will be an hypoxic damage in the brain. And the last is the epiphora, because of the blockage of the lacrimal duct. Patient can have epiphora, and it is quite disabling sometimes. So general management, we need to know, monitor the vitals of the patient. Even if you have stopped the bleeding, but the vitals are not stable, then definitely it is not a good management. So you always look for any low pulse and high pulse, and you need to monitor the blood pressure in view of blood loss and hypovolemic shock. Patient is always in anxiety. And so we need to give some rest to the patient also. We sometimes we can give some mild sedatives also, but the sedatives cannot be very strong, because if by chance that bleeding happens again and then it goes back to your nose in the nasopharynx, the patient in the deep sedation can aspirate the bleeding blood and can go into the pneumonia. Patient if already bled so much, and so the patient might require some blood transfusion for the immediate correction of the hypovolemic shock. Uh, need antibiotics, especially when the nasal packs are in. As I already told you, just to prevent any kind of infection in this thing. And if sometimes the nasal packs are in and the patient is not able to breathe through the mouth properly, we need to know, give the oxygen support to the patient for to maintain the oxygen saturation. And once the bleeding is stopped, patient is vitally stable, and then we can further investigate the patient for to know the underlying cause and uh, for the definitive treatment of the condition. Thank you so much. I hope it was uh, reaching to your side, and thank you so much.